Welcome to the deep dive. Today we are unpacking a quiet transformation that is basically going to kill the doctor's office clipboard forever.
Yeah, which I think we can all agree is long overdue.
Oh, totally. I mean, it's the worst.
Oh.
So we're looking at this June 2026 working paper. It's titled Beyond the Exchange by Dr. F. George Franco Pelka from Episodes of Care Solutions.
Right.
And the mission today is to really explore how the invisible digital infrastructure of American healthcare, the pipes connecting hospitals and clinics, how that's on the verge of becoming this active orchestration layer.
Exactly. An orchestration layer that's going to completely change how you actually experience medical care.
Right. Because the premise here, it challenges this universal frustration. Like you walk into a new specialist waiting room or an urgent care clinic, and they hand you that massive stack of paper.
The clipboard.
Asking you to write down your entire medical history for the 100th time. Every medication, every surgery.
Right. You're sitting there trying to remember, like, did I have my appendix out in 2014 or 2015?
Yeah, exactly. And it's wild because in an era where your phone anticipates your next purchase, healthcare still relies on, your memory and a ballpoint pen.
It's true. We treat the most critical data in our lives as if the internet was never even invented. It's just trapped in these isolated silos.
Okay, let's unpack this, because anyone who has filled out one of those clipboards recently assumes, well, the technology simply isn't there.
Sure, that's the natural assumption.
But Dr. Opelka opens this paper with a pretty shocking reality check about where we actually stand in mid-2026. The underlying technical challenge of getting these different healthcare systems to communicate, like the famous interoperability problem.
Yeah.
It's essentially solved.
It is. I mean, structurally, the pipes are built, the water is flowing.
Wow.
Under the Trusted Exchange Framework and Common Agreement TEFCA, there are now 11 Qualified Health Information Networks, or QHINs, operating at a national scale.
11 of them.
Yeah, and these QHINs, they facilitated the exchange of over 7.8 million documents in their first year alone.
Wait, 7.8 million?
Exactly. The legal architecture holds, the trust frameworks are established, and CMS, the federal agency running Medicare and Medicaid, they've basically mandated that these systems must securely talk to one another.
So the data is moving.
It's moving.
But, okay, if the data is moving, the obvious question you have to ask is why the patient experience still feels so, fragmented.
Right. Why are you still holding the clipboard?
Exactly. And it turns out we're no longer asking if the data can move. We're asking how to turn that raw data into like a treasure trove that actively optimizes your health.
Because moving a file from hospital A to hospital B, that's just the baseline. It's mere exchange. That's rung one on this ladder Dr. Opelka describes.
And that baseline of exchange has a massive limitation.
A huge limitation.
Yeah.
When a primary care doctor queries the network for a patient with complex needs, say heart failure, diabetes, and maybe a recent hip replacement, they don't get a nice cohesive summary.
What do they get?
They receive what Dr. Opelka calls a document dump. Yeah. They might get 40 different clinical documents back from 6 different organizations. And each one is formatted in whatever quirky, proprietary standard its source system prefers.
Wait, so right now my doctor isn't getting like a biography of me. They're getting 40 ripped out chapters from 40 different authors and basically being told to make sense of it in a 15-minute visit.
That is exactly what is happening. The gap between raw data and actual usable intelligence is massive.
That's wild. So how do we fix that?
Well, what's fascinating here is that it forces a crucial shift. We have to move from simply exchanging documents to actively assembling them. That's wrong too. Assembly.
Okay, assembly.
Right. An advanced network acting as a true health data utility has to step up and curate that chaos. It uses semantic normalization.
Which means what exactly?
It means the network recognizes that the acetaminophen prescribed by your primary doc and the Tylenol entered at an urgent care clinic are the exact same clinical concept.
Oh, got it.
Yeah, it deduplicates the records, reconciles conflicting dates, and builds one single computable record, one unified medication list.
And the paper introduces a concept here that feels like, honestly, the holy grail for the patient experience, the clinical fingerprint.
Yes, the clinical fingerprint.
Instead of just a timeline, the network generates this compact, highly dense digital asset. It computes your specific comorbidity burden, your level of frailty, your social context like, do you live alone? Do you have transportation?
Right. Exactly. And crucially, it includes your goals for better, healthy living. Because that fingerprint is computed at the network level, It travels with you.
So your doctors don't have to start from scratch.
Right. They don't have to dig through old PDFs and recalculate your risk profile every single time you walk through a new door. The
No.
network absorbs that administrative burden.
Which shifts the whole system to this computed not collected standard.
Computed, not collected, exactly.
If the network already knows it, the doctor shouldn't have to ask you to write it down. It completely eliminates what Dr. Opelka calls the tax on care.
Yeah, that tax is heavy right now. Clinicians spend half their day manually abstracting data.
Just reading and typing.
Exactly. But with Assembly, the visit can finally start with the question of how to get you better, not a questionnaire about what happened to your appendix a decade ago.
Right. You assemble that load-bearing knowledge asset once, and it serves every provider you interact with. But having that clean, assembled clinical fingerprint, it doesn't just change the individual visit, right?
No, it scales. It unlocks the ability to look at entire populations without hiring armies of analysts.
That's rung 3, right? Synthesis.
Yes, synthesis.
Yeah.
If a network has assembled 10,000 of these longitudinal records, it can suddenly render a complete real-time picture of all the diabetics in a region, or track every maternity journey across a state Medicaid program.
So a clinical registry goes from being this multi-million-dollar manual research project to basically a free byproduct of the network.
Exactly. It's just there.
But even synthesizing population data, that's still just looking backward, right? And what's already happened. The real value here is that a unified clinical fingerprint allows the system to look forward.
Right, moving from description to prediction. Rung 4, trajectory.
Trajectory.
Once the network has your fingerprint and it's synthesized the baselines of millions of other patients, it can plot the probable course of your specific health episode.
Give me an example of that.
Okay, let's say you just had a total joint replacement. The network knows the expected recovery milestones for a patient with your specific clinical fingerprint factoring in your age, your frailty, previous conditions. It maps out your expected trajectory.
Okay, let's apply that to a chronic condition. If I'm, say, a heart failure patient, the network's predictive analytics aren't just passively logging my daily weight from a smart scale at home.
No, not at all.
It's actively feeding that data into a model to flag the risk of decompensation. You know, when my heart can't keep up and my body starts failing, before it gets bad enough to land me in the ER.
Exactly. The system identifies the deviation from the expected trajectory the moment it begins.
Here's where it gets really interesting.
Yeah.
But let me push back for a second.
Sure.
If a computer model correctly predicts I'm going to have a heart failure complication next week, isn't that basically just expensive trivia if my doctor is drowning in 400 other digital pop-ups and doesn't notice the alert?
Oh, you're hitting on a massive structural issue. Alert fatigue.
Right. A forecast that no one acts on doesn't improve my health at all.
I agree completely, and Dr. Opelka points this out. The math for survival modeling and risk stratification, that's decades old. We've known how to predict decompensation for a long time.
So the algorithms weren't the problem.
The predictive algorithms were never the missing link. What was missing was the cross-silo substrate to feed the math. Now we have that. But handing a doctor another dashboard of predictions, useless.
Yeah, they're already overworked.
Exactly. So the network has to close the loop. It has to move from predicting the future to actually orchestrating the care.
Which brings us to rung 5, orchestration.
This is the peak. This is where care coordination becomes both an art and a science. It's the conversion of network intelligence into routed, accountable action.
And this relies on tools like FHR subscriptions, right?
Yes. FHI are fast healthcare interoperability resources. It's the API standard that lets healthcare apps talk to each other. Think of a FHIR subscription like a smart automated trigger.
Okay.
Let's go back to our high-risk patient who lives alone, being discharged after a serious surgery. The moment that discharge is logged, the FHIR subscription detects it.
It sees the event.
Right. And the network checks the patient's expected trajectory, cross-references their clinical fingerprint, and sees, oh, they live alone and are highly frail.
So it knows they need extra help.
Exactly. So instead of sending a passive, easily ignored fax to the primary care doctor, the network orchestrates a specific action. It actively routes a task to the primary care team with all the context attached.
And it keeps tracking it, right? It doesn't just fire and forget.
No, it keeps the loop open until it confirms that the follow-up appointment was actually scheduled and kept.
So the network isn't practicing medicine. It's doing for healthcare what air traffic control does for flights.
I love that analogy.
Right. It doesn't fly the plane, but it makes sure the ER doc and my primary care physician don't crash into each other in the dark.
Exactly. It ensures someone is explicitly accountable. And if we connect this to the bigger picture, This orchestration layer forces a fundamental change in the whole unit of healthcare.
How so?
Today, the system is built around the encounter. An isolated visit, a single claim line on a bill. Orchestration allows the system to finally operate on episodes.
So a knee replacement isn't just a 90-minute surgical encounter.
Right. It's a 6-month arc. Decision to operate prehab, surgery, rehab, recovery.
And that gives primary care doctors, the PCPs, a digital framework that finally sees the patient the way they do, as a whole person moving through time, not just isolated billing events. But managing that sounds incredibly complex. If the system is orchestrating all these complex episodes across different surgeons, specialists, PT clinics, how do the human beings involved visualize this without getting overwhelmed?
That's where Dr. Opelka introduces this visual architecture called the circle of arcs.
The circle of arcs.
Because clinicians think in patient journeys, not document stacks, the circle of arcs parses out this immense intelligence so everyone knows their exact role.
So picture it for us.
Okay, picture a series of concentric circles. At the absolute center, the hub is you, the patient, alongside your core care team.
Okay, I'm the hub.
Right there at the center is the shared knowledge core. Your reconciled meds, your clinical fingerprint, your personal health goals.
And then moving outward from that hub.
You hit the inner ring. These are the foundational arcs stewarded continuously by your PCP. Prevention, immunizations, managing chronic conditions like type 2 diabetes. These arcs are always active.
Okay, and then further out.
The outer ring, these are the episodic and specialist arcs. So a surgical episode or a colon cancer surveillance schedule lives out here.
Oh, I see.
Those outer arcs appear when the journey calls for them. They're intensely managed by a specific specialist, and then they resolve and disappear when the episode ends.
And the brilliance of this is that every single arc draws on the exact same shared core at the hub. It parses out the exact knowledge needed for specialty care while keeping the PCP totally grounded in the whole picture.
Exactly.
So what does this all mean if a piece is missing? Like, let's test the structural integrity here.
Okay, throw a wrench in it.
Suppose I'm in the middle of a surgical episode, an outer ring arc, recovering from a joint replacement. It's a Sunday. I get a weird, painful infection around the wound, and I panic. I go to a random, unaffiliated urgent care down the street.
Okay.
I don't even think to call my orthopedic surgeon. In today's system, the whole outer ring falls apart because that urgent care clinic is in a totally different silo.
Yeah.
Right?
Oh, totally. In a fragmented system, your surgeon has absolutely no idea that happened until you show up at your 2-week follow-up with a massive complication.
Right. But in an orchestrated model.
In an orchestrated model, those core assets at the hub, your meds, your clinical fingerprint, they're load-bearing structures.
Like the steel frame of a skyscraper.
Yes. Assembled once at the network layer. So when that unaffiliated urgent care enters the data about your wound and prescribes an antibiotic, that signal hits the shared core.
And the network instantly recognizes, hey, this event belongs to an active surgical arc in the outer ring.
Exactly. It triggers a FHIR subscription that immediately surfaces a safety signal to your operating surgeon well within the episode window. You build the core once, and every single journey on top of it becomes stronger and cheaper to maintain.
That is amazing. But, you know, a nationwide system actively routing tasks and managing complex health episodes, it sounds like a massive undertaking.
It's massive.
And whenever we talk about healthcare transformations of this scale, the fear is always that we're just building like a bloated tech tool for administrators to optimize billing, rather than something that actually improves human health.
Right. Which brings us to accountability. That's the final piece of the puzzle here. Dr. Opelka outlines the 3 proofs of healthcare value.
Okay, 3 proofs.
Every capability we've discussed must be auditable against 3 distinct questions. The first is proof of service. Did the care actually happen?
Like, did they actually go to physical therapy?
Exactly. With an assembled longitudinal record, verifying that becomes a simple query rather than this massive manual auditing project.
Makes sense. What's the second?
Proof of safety. Did the care avoid preventable harm? Which is historically incredibly difficult to track.
Because complications show up in different data silos, right?
Yep.
Like my urgent care example.
Exactly. If a patient has a severe reaction to a drug prescribed by a specialist and goes to a different hospital's ER, the specialist silo never sees the harm. The orchestration layer gives us cross-network visibility to finally detect and prove safety across the entire continuum of care.
Regardless of where the patient ends up.
Right.
Then there's the third proof, which I think completely shifts the goalpost. of what we even consider success in medicine. Proof of benefit. Did the patient gain what mattered to them?
This raises an important question, right?
Yeah. It's moving from asking, did the hospital successfully submit the billing codes for the joint replacement, to asking, did I actually get my golf swing back after this shoulder surgery?
Which is exactly why proof of benefit is the most absent metric in today's data economy.
We measure costs obsessively.
We do. We measure clinical markers. But capturing patient-reported outcomes, whether they feel better, whether they achieve their specific life goals, it's incredibly rare because it lives outside the billing infrastructure.
But Dr. Opelka argues that tracking patient goals right alongside clinical data streams is the only way to prove real value at scale.
The network has to assemble what matters to the patient, not just what matters to the payer.
That's huge. Giving patients a clinical fingerprint that includes their goals for healthy living and giving PCPs a digital framework that sees the whole person. It redefines the entire purpose of moving medical data.
It really does.
We started this deep dive looking at the digital pipes of American healthcare. The realization that the interoperability problem, just moving documents from point A to point B, is largely solved.
Right. We're moving past the mere exchange of raw files. The system is finally learning to assemble your unique clinical fingerprint, synthesize that data for populations, and use predictive trajectories to map out your health episodes.
All culminating in that orchestration layer, Run 5, the circle of arcs, where the network finally acts as air traffic control, closing the loop, routing tasks, and making sure that your PCP, your specialists, and you're all operating off the exact same load-bearing truths.
And the ultimate outcome of this is just a profound impact on the human experience of receiving care. It transforms care coordination from a frantic series of phone calls and blind spots into a seamless, predictable science.
It allows medical professionals to focus on the art of healing rather than, the administration of disjointed data.
It means the absolute end of the waiting room clipboard.
We are moving from a system that passively hoards your past to one that actively navigates your future. But as this orchestration technology inevitably becomes the backbone of your healthcare reality, there is a lingering thought to mull over.
Yeah.
If we truly reach this level of orchestration where massive interconnected networks are computing your clinical fingerprint, accurately predicting your health trajectory, and actively assigning tasks to your doctors, who gets to define what the expected trajectory is?
That is the question.
As these algorithms step into the role of air traffic control for your body, dictating the standard pathways of recovery and care, how much say will you have in writing the rules for your own biological flight path?